Myself, Dr. Harshashri, Senior Resident in the Department of RadioDiagnosis at SIMS RC, T. Begur. So today we'll be looking at an interesting case of neck swelling where a 59-year-old female with complaints of swelling over the neck region associated with difficulty in breathing and swallowing since 2 months presented to our department with a clinical diagnosis of multinodular goiter with suspicious malignancy with a request for USG neck. So the USG neck was performed, which showed a hypoechoic lesion with few anechoic areas suggestive of a colloid nodules in right lobe of thyroid and isthmus. Multiple such colloid nodules were seen, and the largest one measured approximately 5.2 into 5.5 mm. So here is again a right lobe of thyroid, which shows a hypoechoic lesion representing a colloid nodule. So this is the isthmus part. Here we can see another colloid nodule in the isthmus, which is marked by the arrow. Further scanning towards the left lobe of thyroid, what we could see was a well-defined solid iso-2 hyperechoic lesion, wider than taller, which measured approximately 2 centimeters in maximum dimension with a thin peripheral hypoechoic halo and peripheral rim type of calcification. So this is the rim type of calcification that we can see. And it was assigned as TIRADS 4 nodule according to ACR TIRADS category. Further, on color Doppler images, the lesion showed significant internal and peripheral vascularity. Further scanning towards the lower pole of the left lobe of thyroid, what we could see was a large, well-defined, solid, heterogeneously hypoechoic lesion which measured approximately 6 centimeters in maximum dimensions, which was present predominantly over the anterior aspect of the neck towards left side and abutting the lower pole of left lobe of thyroid. This is the left lobe of thyroid, and this is the lesion where the lesion is seen in close proximity to the left lobe of thyroid, giving us a suspicion of exophytic origin from the left lobe of thyroid. Also, what we could see were few subcentimetric bilateral level 1B, 2 and 3 group of cervical lymph nodes noted with preserved fatty hilum. So some of the DDs for these TIRADS 4 lesions include follicular adenomas, papillary thyroid carcinomas, follicular thyroid carcinomas, medullary carcinomas, thyroid lymphomas and metastasis to thyroid gland. Coming to discussion part, so we have ACR TIRADS category, that is American College of Radiology TIRADS categories, where the thyroid lesions are categorized into TIRADS 1 to 5 lesions based on the composition, echogenicity, shape, margin and echogenic foci. So any lesion with 0 point is assigned as TIRADS 1 benign and there is no requirement of FNAC. Any lesion with 2 points is categorized into TIRADS 4 not suspicious and no requirement of FNAC. Any lesion with 3 points is TIRADS 3 mildly suspicious and FNAC is required if it is more than 2.5 centimeter. And no FNAC if it's more than 1.5 centimeter or follow-up is required. 4 to 6 points, it is categorized into TIRADS 4 where we categorize it into moderately suspicious and FNAC is required even if it's more than 1.5 centimeter and follow-up if more than 1 centimeter. And 7 points or more if it is categorized into TIRADS 5 with highly suspicious nodules, and these nodules require FNAC if it is more than 1 centimeter. So some of the features of TIRADS 4 lesions include thyroid adenomas. So these thyroid adenomas are nothing but true benign neoplasms which are usually less than 3 centimeters in diameter, and they have a well-defined margins which can involute, become cystic, and it can develop internal hemorrhage, necrosis, calcification and or fibrosis. So on USGs, how do they appear? They usually appear as iso to hyperechoic lesion with sometimes with a peripheral calcification. They usually have well-defined margins, whereas carcinomas have poorly defined margins. Next, coming to papillary carcinoma. Papillary carcinoma is the most common type of thyroid malignancy, and sonographically most of these papillary carcinomas are hypoechoic, while sometimes they can have mixed or isoechoic echo texture. Fine punctate intralesional type of microcalcifications are considered characteristic of papillary carcinomas, and these are typically centrally vascularized lesions. So here is a USG image of a case of papillary carcinoma where we can see a hypoechoic lesion with ill-defined borders and few punctate type of calcification. Next, coming to follicular carcinoma. Follicular carcinoma of the gland constitute only approximately 5% of all thyroid tumors, and here women are most commonly affected, that is up to 2 to 3 times more common than men. Then on USG they usually appear as hypoechoic mass. So here we have a case of follicular carcinoma where we can see a well-defined solid hypoechoic lesion with no calcification, and on color Doppler we can see the lesion is showing significant internal vascularity. Coming to medullary carcinomas, these are medullary carcinomas of thyroid is derived from parafollicular C cells of neural crest origin. They are inherited as autosomal dominant trait and can be a component of multiple endocrine neoplasia syndromes type 2A and 2B. And on USG, they are usually hypoechoic and the calcifications are more coarse than a typical papillary carcinoma. So here we have a hypoechoic lesion with the coarse type of calcification in the thyroid gland, which was histologically proven to be a medullary thyroid carcinoma. Next, coming to thyroid lymphoma. Thyroid lymphoma is usually uncommon and usually presents in a case of elderly people with a history of long-standing goiter, and they are seen as either solitary or focal hypoechoic lesions with diffuse enlargement of the gland, and it's often difficult to distinguish from Hashimoto's disease. Also, it can be associated with cervical lymphadenopathy. Here we can see there is a diffuse hypoechoic mass that is present in the left lobe of thyroid. Also we can see the lesion is extending into the the surrounding tissues of the thyroid and encasing the left common carotid artery. So coming to the table of differences between the Tirard's 4 lesions that we have: adenoma, follicular carcinoma, papillary carcinoma, medullary carcinoma, lymphomas and metastasis, and their appearance on USG. So follicular adenomas are usually hyper to isoechoic with smooth margins and peripheral calcification with a thin complete halo and with no evidence of significant lymph nodes. Papillary carcinomas are usually hypoechoic, irregular with fine punctate type of microcalcification with absence of peripheral halo, and lymph nodes can be common. Sometimes they can be associated with cystic lymph nodes. Follicular carcinomas are hyso to hypoechoic. They can have smooth or irregular margins where the calcification is rare, and they have a thick or irregular peripheral halo. With less common lymph nodal involvement, you cannot distinguish follicular carcinoma from adenoma. Medullary carcinomas, they are usually hypoechoic with irregular margins and coarse type of calcifications, and they usually they do not have peripheral hypoechoic halo, and lymph nodes can be seen in early course of the disease itself. One important special feature is there will be increased calcitonin in case of medullary carcinoma, which can be used as a tumor marker. Thyroid lymphoma is markedly hypoechoic with lobulated margins with rare calcification and absence of peripheral halo and associated with lymph nodal enlargement. Also, there will be history of Hashimoto's thyroiditis. Coming to metastasis to thyroid gland, they are often hypoechoic and often multiple with irregular margins with absence of calcification, absence of halo, and variable lymph nodal involvement with a known primary cancer. So these are my references. So the take home message is the American College of Radiology TARADS category is very important in classifying the lesions, thyroid lesions on USG, and for the further management of the cases. Thank you.